So the case is you're a foundation year 2 doctor in the A&E department. Trevor Andrews is a 66-year-old man who's presented with unilateral leg swelling and malaise. Other information you have, he underwent a hip replacement 10 days ago. What you must do, assess and discuss management with the patient. So obviously looking at this case, you might have kind of ideas about what you think this might be, but let's try and keep it as open as possible so that we don't end up wrongly diagnosing the patient or missing an important diagnosis. So just try and stay systematic, follow your structure, and address any cues, and make sure you listen to the patient. So we've been doing them under timed conditions. Is that okay?
Yeah, that's okay.
Have you been practicing with a timer?
No.
Right, okay. Ready when you are.
Okay, I'm ready.
Right.
Hello.
Hi.
One of the foundation year 2 doctor in accident and emergency department. Can I confirm your name and age?
Hi there. My name is Trevor Andrews. I'm 66 years old.
Nice meeting you, Trevor. Can I call you Trevor? Is that okay?
Yes, that's fine. Yeah.
Okay, Trevor. What brought you to the hospital today?
I got this swelling on my right leg.
Okay. Can you explain me more about your swelling?
Sure. Yeah. It's I've had it since this afternoon. I was just sitting watching telly, and just noticed this swelling came on pretty quick. To be honest, quite painful as well.
Okay, it's painful. Is it okay for you to continue, or should I prescribe some medication before we continue?
Yeah, I mean, I wouldn't mind some medication. I mean, it's not like unbearable. I can talk. That's fine. Yeah.
Okay, that's good. Okay, Trevor, can you just tell me when did you first notice it?
Yeah, like I said before, I noticed it this afternoon when I was watching telly.
Okay, and okay, so what's the thing that's making it worse?
It's kind of there all the time. Nothing really makes it worse. No.
Okay, and have you taken anything or did something to pain to make the pain go away?
No, I thought I would leave it to when I come to doctors just in case. So I haven't taken anything. No.
Okay, it's there for this afternoon. Before that, there wasn't any swelling or pain.
No, there wasn't. No. I have had an infection in my hip, wound infection after my operation. So I've been taking antibiotics for that. That was painful, but it really settled down after a few days of taking the antibiotics. But now I've got this whole leg that's swollen up. I don't know if it's related or if the infection has spread or what.
When did you had this hip infection?
So I had that, I'd say about a week after the surgery.
Okay, so you had the surgery. Can you tell me more about surgery? What surgery you had?
Yeah, I had my hip replacement.
Okay, and what was the reason for that?
Reason I just got really bad arthritis.
I'm sorry to hear that. Okay, Trevor, can you tell me were you prescribed any medication after apart from the antibiotics? Any blood?
No, I wasn't. No.
Okay, and have you been mobile? Are you moving after surgery, or you're just on bed?
Yeah, I mean, the doctor did explain to me the first few days I've got to, walk around and stuff. Don't spend too much time in bed. I was doing that, yeah, quite a lot. But then after the infection, I've kind of been resting a bit because I wasn't feeling very well.
Okay, so is your infection getting better so far?
Yeah, it did. Yeah, after 2 days, just took the tablets for 2 days, and it was a miracle. Really improved a lot. But now,
okay, that's good to hear that.
Now it's my whole leg.
Okay, and you have the swelling. Is it the swelling going somewhere else, or at the other leg, or is it in the abdomen as well, in your belly?
No, it's just kind of it finishes, I'd say, just above the leg.
Okay,
Just above the knee. Sorry.
Okay, below the knee. So you have any lump
Above the knee.
just behind the knee? Any
Above.
lump behind the knee, obviously above knee?
Oh, no lumps behind the knee, no.
Okay. So like, is it making you difficult to walk?
Yeah, it is, yeah.
Okay. And any changing in the swelling so far?
Changing the swelling?
Yeah.
Yeah, it's just getting worse, doctor, yeah.
Okay. Okay, Trevor, I would like to ask some more questions about your past medicals to be clear about your condition. Okay.
That's fine, that's fine.
Do you have any past medical history about anything else?
Not really. I've got varicose veins. I had those for a while. Got them in the back of my leg. Same leg as well. I don't know if that's related.
Okay. And was it treated?
No, doctor said
Okay.
it's fine. It's not worrying him.
Okay, it's not worrying. Okay. And do you take any medication apart
Yeah,
from
I
the
forgot.
antibiotics?
Yeah, I do. I take Ramipril. I forgot to mention I do have high blood pressure as well.
Okay, you have high blood pressure. Are you compliant with that?
Yeah, I take that. Yeah.
Okay. Okay. Do you have any allergies to any medication?
No allergies. No.
Okay. Any past like family history of this varicose vein or any heart problem, anything else that runs in the family?
Oh gosh. My mother had a blood clot in the lung, but probably not very related.
Okay. And is she doing well?
Yeah, she's fine now. Yeah, she recovered well.
Okay. Okay, that's good to hear. And do you have any travel history recently?
No.
Okay. So what do you do for a living? Like,
Yeah, I'm a builder, but semi-retired.
okay. And do you live in your own house?
Yeah, I do with my wife. Yeah.
Okay. And you live alone?
No, with my wife.
Okay. So she's taking care of you. Okay. Am I right?
Well, yeah, I'd say I take care of her more than she does me, but yeah. Okay, we'll say
Okay. Okay. How's your diet so far? How's your diet?
that. Yeah, diet's all right. Burgers and pies, mainly.
Okay. Okay. And do you exercise like regularly?
Not really, no.
Okay. Okay. And do you smoke or drink alcohol?
Yeah, I must say I'm a big drinker. Yeah, I'm a big
Okay.
drinker,
For
and I
how long you
smoke.
have been? For how long have you been drinking?
Oh gosh, I think I had my first drink when I was about 8 years old.
Okay. Okay.
But yeah, I drink, big one on the weekends. Yeah.
Okay. You drink only on weekends?
No, I drink every day.
Okay. Okay, Trevor. Good. Okay. I would like to examine you. Would that be okay?
Yeah.
Okay, I'll take your vitals and I will examine your lungs, chest, and legs. Okay.
Okay.
And I will also like to run some blood tests. Okay, like that would include your D-dimers and your blood CP. Okay.
Okay.
And should I continue?
Yes. Yeah.
Okay. Okay, Trevor. Okay, so basically blood test. So result.
Yeah. So the observations: temperature 37.9, heart rate is 102, respiratory rate is 18, sat to 94% on room air, blood pressure is 140/95. On examination, you saw that. There were also some varicose veins on behind the knee.
Okay.
In the distribution of the short saphenous vein.
Okay.
So on measurement, the diameter of the calf, the right calf, was more than 4 centimeters compared to the left, and home enzyme was positive.
Okay. Okay, Trevor, I have examined you, and I would like to ask that, do you have any concern in your mind that what could be the possible cause of your swelling?
Yeah, I suppose I'm concerned that I've got a spreading infection. Yeah, I think that's
Okay,
what it is.
okay, I appreciate your concern. And what would you be expecting from me?
I'm expecting, like the antibiotics were good and stuff, but I think I need some stronger ones this time to help because it looks like the infection's getting out of control.
Okay. Okay, Trevor, from my assessment, I think you got this condition, which is known as deep vein thrombosis. Have you ever heard about this?
No, what's that?
Okay, it's a condition where basically, there's a blood clot in your vein that blocks the blood supply.
Right,
Okay.
okay. A blood
Okay,
clot.
and yeah, so
Oh,
there are like multiple risk factors. Okay, sorry, continue, Trevor.
no, that's it. Continue, that's fine.
Okay, so in your condition, assume that it's you have like risk factor, you had surgery recently, and you haven't been mobile after surgery a lot. So this is one of the like risk factors that could be leading to this problem. But yeah, you are here with us, so we can treat it. So that's a good thing to do. Okay.
Okay.
Okay, Trevor, we're gonna admit you. We're gonna run a leg ultrasound. That's known as Doppler ultrasound to know about your veins. Are they like good, or the position of the blood clot where it is, and what could be possibly be done for that. And we're gonna involve a vascular surgeon as well, just in case if we need any surgery for that. Meanwhile, we're gonna do. Meanwhile, when you're waiting for this ultrasound, we're gonna give you blood thinners as well. Okay.
Right, okay.
Okay, and for the pain, definitely you will be managed. We're gonna give you a painkiller for that. That will keep your pain under control. And till then, I'll advise you to keep your leg raised, the affected one, and do not cross your legs. Okay.
Okay.
Okay, and you need to keep at least do some physical activities, just do a 30 minutes walk a day, uh, like after you get discharged from the hospital. And yeah, you have to keep your leg raised. And secondly, you will be offered some oral blood thinners that you have to continue for 3 months.
Okay.
Okay.
3
Okay,
months.
and in
Okay.
case you have in case you have any shortness of breath or like cough with blood in it, or like any swelling that's getting worse, or your pain is getting worse even after the treatment, immediately call 911 and just seek the hospital. Okay.
Okay. 911. 999, yeah. Okay.
Okay. Is there anything else you would like to ask?
Uh, so it's not an infection then, doctor? I thought I was having an infection.
No, it's not an infection. Since you I appreciate your concern, you're thinking about that, but since you have positive risk factors, you have a surgery, and you are immobile, so I'm thinking of like this. But I'll also involve my senior just to be on a safer side. Okay.
Okay, yeah, thanks a lot, doctor.
Okay. Welcome, Trevor.
Is that the end?
Yeah. Done.
Excellent. Yeah, that was good.
Okay.
Yeah, I mean,
And
it is
was it?
difficult. I mean, in the exam, I did give you too much information, so it was kind of like, it's difficult to fit it all in. But if you were expected to do a history and manage and discuss initial management in this case, and you were only given 8 minutes, the patient would help you by giving you much more concise answers than what I gave you. Okay. So
Okay.
I don't think I was too concerned about time in this one, because I think you more or less covered, you addressed all the key themes within the time period, I think.
Uh,
Is that right? I'm not sure exactly
I
where it ended, but it felt like you
I
kind of finished most of
the
it.
time, I guess it was 13 to 14 minutes, or maybe more. I don't know.
Yeah. Yeah, I think with this one, I thought it was really good that you mentioned about your management. You've obviously read up on the CKS NICE guidelines for the management of DVT. So that's really
Yeah.
good because in a case like this where a DVT is likely, considered likely according to the world score, because he would score over 2, he needs to go straight away for a duplex scan. Shouldn't wait for and in the interim he should be given anticoagulation. First line being the direct oral anticoagulants, apixaban or rivaroxaban. Those two are the preferred ones. But yeah, so that's good. So you identified that. That was a key theme in this, is that you need to exclude a DVT as soon as possible. So that's number one key theme. By the way, your communication skills were good. You spoke very clearly. I think there wasn't too much hesitation, and there was a nice structure. I could see that you were following a structure, and I think that'll give confidence to the examiner that you know what you're doing and you're quite systematic, I think. Yeah, just apart from that, I thought overall it was really good. You addressed all the key themes. Just two things I would say. One is really small. It's just the in the UK the emergency number is 999, not 911. That's the American one. So make sure you say 999. But otherwise, the safety netting was good. Yeah. And the other thing was at this stage, even though you mentioned going for a D-dimer and other blood tests, I would say it's too soon to be that confident on your diagnosis. I'd say it's a little bit too soon. And who's not to say that the infection and the DVT are coexisting together? So I wouldn't be so quick to dismiss an infection just because it looks like a DVT is likely. He could also have an infection coexisting, which is a risk factor for developing thrombosis anyway. So I would just be a bit more cautious at this early stage with being definitive with your diagnosis and with addressing his concerns on infection. Any other comments, anybody, before we move on to the note?
I'd like to add something. Actually, there was an article there before, someone written by a previous examiner. So she said you should never mention vitals in the exam. Examiner said that word. You have to say, I'm going to observe you for your oxygen stats, your temperature, your blood pressure, and your heart rate. Don't say vitals. Examiner said that word.
Right.
Okay.
Yeah.
Thank you.
So let's have a look at the note. So nice open question at the beginning, which you asked. Odd power of the swelling. So what kind of differentials did you have in mind at the time when you were taking this history?
I had this thrombophlebitis, for which I asked do you have any changes in do you have any change, do you feel any changes on your swelling? I guess I had
I didn't quite understand that question when you asked that. What do you mean by any change? Did you say skin changes?
Yeah, skin changes like this.
Because skin changes, yeah. I thought you said changes in the swelling.
Yeah, and I asked about Baker cyst and that's it. I didn't have any this cellulitis. Yeah, that was an option, but since cellulitis is you mostly get to see it on examination. You confirm it on examination, you see the demarcation like this and that, and it's like a redness.
Right.
So I just left it on examination.
So redness, but wouldn't the DVD also have redness as well? What would differentiate cellulitis
there's a
from?
proper demarcation, there's a demarcation, demarcating.
Yeah. What else would differentiate it from DVT? What else in the history, examination, or investigation would allow you to differentiate a DVT from cellulitis?
The patient would complain about the
fever.
Yeah, again, it's difficult with fever, but you'd expect a higher grade fever in cellulitis and maybe a mild fever with DVT. Could be without fever. But yeah, that's I suppose the blood tests, that's where they come in handy. So the inflammatory markers and the scan later on. Yeah.
Blood as you.
Yeah, and the superficial thrombophlebitis kind of can sometimes look like a swollen leg, and so really to differentiate between a DVT and a superficial thrombophlebitis, you just need to do a scan. But yeah, I think varicose eczema is another one to consider because of his history of varicose veins. But yeah, otherwise that's the only one I would say to consider. Just red flag. Towards the end, you were talking about safety netting. What were the symptoms you said for safety netting?
Shortness of breath and any hemoptymasis and pain.
Yeah. Pain. Whereabouts the pain?
Chest pain.
Chest pain. Yeah. Okay, so you're thinking about pulmonary embolism there. Yeah. Also, it might be worth asking about weight loss again, because cancer. You need to. We're thinking about the common risk factors for DVT, right? So what are we thinking about? Okay, recent surgery. Okay, he's had recent surgery. What else are we thinking about? Okay, post-partum. Okay,
He had recent surgery. He was hypertensive, and his age was 66. And yeah, he wasn't mobile that much.
But yeah, cancer is definitely something to look into as well.
Yeah.
But unlikely because he's just come out of surgery. So that kind of does give it away that he's 10 days post-op. But the other risk factors as well, which you picked up on, the family history of PE, which he thought wasn't related. And also he's a heavy smoker as well. I don't know. We talked a lot about alcohol. Did you ask me about smoking as well?
No, you only mentioned alcohol.
Right. Okay. Yeah. Yeah. So he is a big smoker as well. So that would increase the coagulability, which would contribute to the formation of DVT as well. That was something you did really well as well, which was address the risk factors. You screened really well for risk factors of DVT. So I thought that was really good. Another key theme in the case. Yeah, so I just put a note here just to say when he asks about infection, don't commit to an answer. Could be a number of other things that need to be considered first, need more tests, which is what you did at the beginning in the history. But then later on, after the examination, you were kind of more set in stone. But I think it was still a little bit too early. I would have still kept it a bit more open.
Okay.
You know, that's definitely something that we're going to consider.
Okay.
Yeah, so vascular examination. So did you say we'll check the pulses? Make sure you
Sorry?
the leg. Did you say you're going to check the leg pulses?
No. I just said I will do the leg examination.
Right, okay. Yeah, I would emphasize, just to be clear to the examiner, I would emphasize including, all the peripheral pulses.
Okay, yeah.
Right. So this is just one way of approaching it. So you could say, looking at what you told me and from my examination, I think there are a few things that this could be. The first is a blood clot in the vein, what we call a DVT. DVTs mostly occur in the leg. Increased risk. So there is an increased risk in people who've had recent surgery, especially hip surgery or leg surgery. There's also an increased risk with people who've got varicose veins, people who have an infection, and in smokers as well. And also you could tell them that that you've noted that that his mother had a blood clot in the lung, which could be related as well. That could indicate a predisposition to getting blood clots, or an increased risk in the family to getting blood clots. So I think the important thing to say is, if it is a DVT, it's important that we treat it as early as possible to prevent complications like a blood clot in the lung, which can sometimes be life-threatening. So that's an important point. That's another key theme in this case.
Okay.
And which you did, by the way, because you addressed that in your safety netting, so that's fine. So risk of PE, That's another key theme. Risk factors, doing an assessment, identifying the relevant risk factors. That's another key theme. And finally, you know, giving therapeutic dose of anticoagulation as soon as possible. Alternatively, it could be a smaller blood clot in a vein on the surface of the leg. This is not serious, and it resolves on its own. We usually just give something to help with the pain. If you think you are absolutely, I think you are absolutely right to consider a progression of the wound infection, and we do all the necessary tests to look into this. DVTs and infections under the skin in the leg often present in very similar ways, but there are a couple of tests and investigations that we'll do to differentiate between the two. So again, that's just a suggestion of, they're the three main ones that I would, you know, point out to the patient as possibilities, and then you know, saying that we're going to have to do some tests and investigations to differentiate between them. So yeah, your management was in line with the latest guidelines, which were updated recently in 2022 following the pandemic. So I think after the pandemic, there was a big push towards using direct oral anticoagulants to treat patients with venous thromboembolism. So that's pretty much used throughout the UK now. Apixaban and rivaroxaban are the preferred direct oral anticoagulant agents that are used. And so you would give those. So preferably you would aim to do the scan within 4 hours. Now that's going to differ depending on which trust you're in and which specialty you're working in, and whether it's, you know, if it's in primary care or secondary care, that's all going to differ. But that's what you should aim for. So if you can't get it done within 4 hours, then you would, you know, that's where the D-dimer comes in more handy. But there isn't really a need to do D-dimer in this case. I think because what we're doing in the exam, for the exam, we are trying to follow the guidelines as strictly as possible. And so that might mean neglecting what they would actually do in practice. So in practice, they would do it, you know, take a D-dimer along with the rest of the blood. But according to the guidelines, you wouldn't do that because the scan is really what's going to diagnose it definitively. The D-dimer, as you all know, has a high sensitivity but a low specificity. So it's only really useful in excluding the diagnosis of a DVT, but not very useful when it comes to confirming it. So yeah, I think, you know, ideally what we do is we'll send you for a scan. If that's positive, then we'll give you the therapeutic DOAC, and you'll be admitted and be seen under the care of the hematology team or medical team. Alternatively, if the duplex scan is not available, the result that is within 4 hours, then you would do the D-dimer, give interim therapeutic coagulation, and then aim to get the duplex scan results within 24 hours. So that's probably what happens is more likely to happen in practice, is that they'll do a combination of the two. So yeah, I mean, with the Wells score, so I calculated it as 4 using the app, but it may be that I've missed some. But the important thing to note is that if it's 2 or more, then a DVT is likely, and so you should treat it as if it was a DVT. So you need to send them in for a scan as soon as you can. And you shouldn't wait for the results of the baseline bloods before starting anticoagulation. You can make adjustments later on. So start the DOAC as soon as possible. And then, like you said, you know, once they're discharged, they can continue those for 3 months. They'll need to be followed up in the anticoagulation clinic during that period. Yeah, stockings is good to prevent the risk of post-thrombotic syndrome, which can affect them in the long term. So yeah, that's really good because that's really important to the patient, pain and all those kind of symptoms they get in the leg. That can affect them for a long period of time. So it's good to try and encourage them to use stockings from as early as possible. Yeah, so if it was cellulitis, then you would also most likely admit and give supportive treatment and IV antibiotics. Just an important thing that because we had a case before where somebody had a renal colic and they also had a urinary tract infection, and you know, that flustered the candidate a little bit, because they kind of switched from their first differential, which at the time was renal colic, they switched to just a UTI on its own. So just be careful, just try not to think, you know, too black and white, and think that these things do coexist. Patients are complicated, so things don't always fit into what you're thinking perfectly. They can coexist or have some elements of one thing and other elements of another. Yeah, superficial thrombolymphitis, you just determine that in the scan, really. Just the 6 Ps. So which changes in the leg did you ask about? So you mentioned skin changes in the leg.
Yeah,
I would also,
it was like 6 Ps.
yeah, so the acute limb ischemia.
Pallor, paresthesia, pain, pulselessness, and paralysis, I guess.
Yeah, and perishingly cold. So those 6 Ps, anyone that's kind of is presenting with acute onset of pain in the leg, in one leg, I think that's worth considering, or in both legs as well. It could be an occlusion that's more proximal, and so that could cause pain in both legs. But yeah, like 6 P is definitely something to look into. So I say, you know, for your red flags and safety netting, they kind of go hand in hand together. So I would say, you know, always for those two, for this kind of case, unilateral leg swelling, you need to think about PE and you need to think about 6 Ps as well. So try to remember, you know, asking 1 or 2 questions about 6 Ps. You did ask, you know, if I could walk, which kind of that covers you for paralysis. You did ask about skin changes, so that covers you for, you know, the color pallor, for example. So yeah, like, yeah, but I would try and, you know, I would mention the neurological ones really are the ones that were missing there in that history. So I would definitely talk about that, paresthesia, tingling or numbness, anything like that. But yeah, excellent. You mentioned senior opinion, but you basically ticked off all the boxes, and so you would do absolutely fine. Well, that was very good and well researched as well. Just yeah, one thing is the CKS NICE guidelines. We've got to give management advice that is in line with those guidelines. That's really important, and not just the CKS guidelines, but also when it comes to prescribing, we need to say things that are in line with BNF. So always do check BNF and do check the NICE guidelines, and do check as well for the acute scenarios as well. The resuscitation, or the, you know, the algorithms and all that for acute scenarios as well. Definitely make sure that the advice you're giving is in line with those. Any other comments from anybody else at all?
It was a bit of overtime.
Yeah.
Yeah.
So, I mean, it was really good, but if she had managed it within the 8 months, I mean, I don't think so they'll consider anything beyond 8 months. That's a bit tough.
Yeah, where was it?
To manage all this in 8 months, but it was really good.
Yeah.
Thank you.
Where was it that it ended, that your time ended? Did it run out as you were just talking about admitting me, or was it a bit later than that?
I think it's 14 minutes, to be honest. Like, I had this time.
Right.
History took 7 months. I mean, the whole time was the investigation, and management was really good, but if she incorporated within the 8 months, that would be a bit more beneficial for her.
Yeah. Yeah, just one thing to bear in mind is that I am giving you, just to make the case, just for the purposes of the learning for everyone that's you know, watching the recording, I am, you know, making the cases a bit too detailed. But yeah, I think the actor will make life a lot easier for you by giving you concise answers and giving you negative responses to a lot more questions, whereas I tended to have positive symptoms for everything. So yeah, so I don't think, you know, you can't take all responsibility for that. A lot of that is me as well in my answers. So I'm not making it easy for you. But yeah, actors will be really good at you know, knowing when to be quiet.
During the exam, right?
What's that?
I mean, during the exam, the actor or the patients will be a bit more concise.
Yeah, they will. Yeah, much more concise than I've been. Yeah.
So we can manage the history within 4 to 5 minutes, hopefully.
Yeah, I think if that's really the cutoff point. I think if you start getting past 5-6 minutes, then you're going to really sacrifice marks in management. So the YouTube video is a guide, and I would say you probably might need, depending on the case, you need to assess kind of in this case what are the key themes. Are the key things related to the information gathering part of the consultation, or are the key themes more related to the management? And so you need to think, with this one, I would sacrifice exploring the risk factors a little bit in order to talk more about the management. Because the risk factor that was given, that was in the case, makes it quite clear that he had a hip replacement 10 days ago. And so I think once he starts giving you the details about the infection, the wound infection and the operation, you've pretty much got what you need. I slipped in all those extra little things just for the purpose of learning and everything, for us to revise the risk factors. But I think, once you've got there, you don't need to explore that too much more, I think, because at the end of the day, whether it's, like you said before, whether it's an infection or a DVT, there might be some hints in the history that will point towards one and against another, but really you're not going to know until you do the scan and the blood test. Yeah. So really, if you don't have time to say that you're going to do the scan or the blood test, then that's a problem. Do you see what I mean?
And they'll provide us the lab results during the case if we ask them.
Yeah, so in this case, my intention was not to give any lab results. This was just the observations, examination findings. That's all I was giving you. So you don't have back any blood test results yet. That was intentional, yeah.
So we have to just give our provisional diagnosis on the basis of examination findings.
Yeah, that's why it's not good to commit to one thing necessarily. You need to talk about the different things that it could be.
It could be.
Yeah, I would be very, very careful committing to something. Even if you're almost sure that something is something, I would not say it's this.
It could be this and it could be that, and I mean, it might take time to just confirm the diagnosis.
Always be cautious with the diagnosis. You don't want to lose marks by giving the wrong diagnosis and falsely reassuring or excessively worrying the patient, or giving them the wrong information. That's not good. So always be very cautious. I would say, even if you're sure it's something, I would say most likely it will be this. Yeah. That's like if you're 100% sure, I would say most likely. I still wouldn't say it's this. Yeah.
As an FY2 doctor, right? We are junior doctors, so we just can't be 100% sure about anything.
Unless you've already got the investigation, the results from the investigations. You've got all the blood tests, you've got all the scan results, you've got everything, and you've made an assessment, and you've been able to determine that, so for example, someone presenting with vaginal discharge and you do a culture and it comes back positive for Gardnerella vaginalis. Well, that can only be bacterial vaginosis. So you've got the diagnosis there. Then you can be definitive with how you talk to the patient, tell them you've got this and this is the treatment. But until then, at this early stage, we have to be as open as we can and not commit to anything. By all means, discuss the different options, like different possibilities, and your reasons for thinking or swaying more towards one thing compared to another. But yeah, give them, tell them about your thought processes if you're not sure, and tell them, I'm more inclined to think it's this, but it could also be this, but less so because of this, that kind of discussion. Yeah. So remember, this is a provisional diagnosis. Yeah. So don't be afraid to mention more than one thing.